Ashma would be presenting this topic on diagnostic approach towards AKI. So let us know about a few facts. Now, this term represents the entire spectrum of acute renal dysfunction, and AKI itself is an independent risk factor for increased in-hospital mortality and long-term outcomes. So outside critical care, there is this rare occasions where we actually measure urine output. Now, if we see in healthy adults, for example, with a typical GFR of around 100 ml per minute, without developing any renal problems, they can make in and around a liter of urine per day. The same adult, if is deprived of water, with the help of neurohormonal mechanisms, the urine output would drop, but there is this maximal urinary concentrating capacity. So because of this mechanism, or this what we call RAS, hypothalamic pituitary and ADH axis, there is this obligatory minimum urine output of around 500 ml per day. Because of these mechanisms, even when the cardiac output and blood pressure are maintained, so in cases of pain, surgical stress, venodilatation, or hypovolemia, there would be this water and salt retention. So let us quickly go through this classification of AKI, which I have another table where it shows a Rifle, Aiken, and KDIGO classification. So in Rifle classification, we have this, one second, just a minute. We have this risk, injury, failure, loss of kidney function, and end-stage kidney disease. So that, depending on the GFR and creatinine and urine output, it has been classified into these 5 stages. So in the risk stage, there is this rise in creatinine by 1.5 times, and the GFR is dropped by more than 25%, and the urine output is less than 0.5 ml per kg per hour for 6 hours. Whereas the injury stage, the serum creatinine doubles, the GFR reduces by more than 50%, and the urine output is less than 0.5 ml per kg per hour for 12 hours. When we reach the failure stage, the creatinine is increased by 3 times, and the urine output drops by 0.3 ml per kg per hour for 24 hours, or there is anuria for 12 hours. Now, the loss of kidney function is termed when there is complete loss for more than 4 weeks. And end stage is termed as when the complete loss is for more than 3 months, as per the Rifle criteria. Now we see the Aiken classification. As per Aiken, now it uses creatinine and urine output as the guiding factor. So in stage 1, the creatinine rise is more than 0.3, whereas the urine output is less than 0.5 ml per kg per hour for 6 hours. In stage 2, it is twice the baseline, and in stage 3, it is 3 times the baseline. Or if the baseline is more than 4 milligram per deciliter, and the urine output is less than 0.3 ml per kg per hour for 24 hours, or anuria for 12 hours. And sorry. And the third classification is the KDIGO, that includes 3 stages, that is the increase in creatinine by more than 0.3 within 48 hours, or 1.5 to 2 times the fold from the baseline. The second stage includes almost 3 times, 2 to 3 times from the baseline. And the third stage is 3 times from the baseline of the serum creatinine, or the baseline creatinine is more than 4, or initiation of renal replacement therapy, or in patients of less than 18 years, there is a decrease in GFR. Now, basically, when we have this patient with AKI, so first what we go through is the history part, physical examination. We review the medical records. Then we see or get in some lab and radiographical investigations. So we'll go in stepwise. So physical examination and history. So what are the signs and symptoms that we initially see or examine the patient with? We look for fever, whether there is any hypotensive episode, whether the patient is breathless. Hypotension can be seen in septic shock or a reduced cardiac output because of various reasons. There can be dyspnea, hemoptysis, which could indicate of some pulmonary renal syndrome, any trauma or GI bleed, which could result in pallor, edema, that we have to assess the volume status of the patient, icterus, any fever with rash and arthralgia that would indicate vasculitis or some sort of viral infection. Mentation, if the patient is having altered mental status or what do you say, psychiatric patient who has had drug overdose, or a patient with HUS who has altered mentation, fever, and the symptoms of HUS. Then lower abdominal distension, patient might be having some bladder outlet obstruction or abdominal compartment syndrome. A patient might complain of flank pain, so we should rule out whether there is some stone related issues, renal vein thrombosis, or renal infarct. So along with these signs and symptoms, we should also look into the comorbidities like diabetes, hypertension, obesity. We should look into the age group of the patient, any underlying liver or cardiac history. Now, renal insults are also caused by nephrotoxic agents, drugs, contrast, whether the patient has any history of trauma or is a post-CABG patient. So when we review the medical records, like we said, that's also a part of history, what drugs they have taken, whether they have taken any NSAIDs. Patients with, for example, chronic osteoarthritis, they have this chronic use of NSAIDs. What kind of antibiotics, the previous hospitalization or at home, what they have taken, which can be nephrotoxic, whether they were on any diuretics, any chemotherapeutic medications that they are on. Commonly, we see patients who are having this long-term or acute use of some Ayurvedic medications, which can be nephrotoxic. Then there can be this drug overdose, like I told. Any imaging that has involved use of contrast, or like we told, CABG, or any surgical patients where they have had intraoperative episodes of hypotension or a nephrotoxic drug. Then we go through lab investigation. So early stage of AKI often remains unnoticed. Now that's because serum creatinine lags by almost around 24 to 36 hours. So oliguria in the presence of biochemical renal dysfunction, it has been indicative of a most severe kidney injury. Now that has been associated with more need of RRT and higher risk of death. There have been several observational studies where it implies that AKI in the presence of volume overload has a worse prognosis. So a bit of physiology, that creatinine is majorly synthesized in the liver and to a very less extent in the kidney. The major reservoir of creatinine is the skeletal muscle. So from there it enters the cells via membrane transport system. It enters the cells and there is this creatinine, phosphocreatinine, creatine production, and through that ATP is generated. Now creatinine is a spontaneously formed derivative of creatine degradation in the tissues. So the basic use of creatinine for assessment of renal function relies on the rate of excretion being approximately proportional to GFR. So what's the relationship between GFR and creatinine? So GFR into creatinine is equal to, or we can say is equal to the creatinine generation rate. So this relationship forms the basis of the increase in creatinine from the baseline to define the severity of AKI. This is what do you say, used in the rifle criteria that would reflect in that definition or classification. But the limitations are that the use of plasma creatinine it's an indirect measure of GFR and is unreliable outside the steady state. So the changes in creatinine production can alter the measurement of plasma creatinine as much as the changes in excretion, that's the GFR. For example, in sepsis, a patient with a lean body mass, increase or decrease in the dietary intake of creatinine, or a presence of liver disease. So direct measurement of GFR is not done. So it is a calculation which is that the urinary creatinine divided by plasma creatinine into the urinary flow rate that accounts to GFR, which is measured in ml per minute. So the aim is that it tells us the global measure of the kidney excretory function. So the normal GFR is around 120 ml per minute per 1.73 square meter of body surface area, which above the age of 20 declines by 0.5 to 1. Now, plasma creatinine is excreted from the bloodstream predominantly by GFR, and thus, as GFR decreases, the creatinine will accumulate. So the acute alterations, it requires an understanding of the steady state dynamic kinetics of the creatinine generation and the excretion. Now, a bit about urea. It's a water-soluble byproduct of protein metabolism, and it exhibits a reciprocal relationship with the GFR. But its drawbacks are that it is 50% reabsorbed by the proximal renal tubular cells, and it is variable in cases of when diuretics are used, when there's hypovolemia, in acute or chronic kidney disease. So it is the urea production is increased in high protein intake, catabolic states, GI hemorrhage, whereas it may be reduced in acute or chronic malnutrition and liver disease. So hence the urea clearance is, or it's not recommended for GFR estimation, particularly under non-steady state conditions. Now, there's another marker called cystatin C, which is a cysteine proteinase inhibitor, and it is synthesized by all nucleated cells and released into the plasma. Now, the main catabolic site is the proximal renal tubular cells, and more than 99% is filtered by the glomerulus. So it is not or very minimally present in the urine. So its urinary clearance cannot be determined. There is a lack of standardized method for its measurement, and it is also affected by elderly age group. If the patient is a smoker, whether there's whether this patient is using steroids, there's an abnormal thyroid function, or raised CRP levels are noticed. So what's an ideal marker then? Like, what are the qualities that it should have? It should be sensitive and specific in detecting small changes in GFR. It should be detected early. It should not be secreted, metabolized, or reabsorbed by tubular cells, easily measured, and should not be influenced by exogenous compounds. So our basic test, that's the urine routine. In a urine routine, what we see is the supernatant that is there, the color of the urine, the supernatant, or the casts. So on that basis, if we have a frank hematuria in a patient, so that could be indicative of a glomerular injury. If there is hematuria in presence of proteinuria, that could be indicative of parenchymal renal disease. If there's a red supernatant, that could be indicative that there is hemoglobin in the urine or myoglobin in the urine. If it's green colored urine, then could be possibly that a patient is on a propofol infusion, when you can notice such difference in the color of the urine. When we see white cell casts in a microscopic examination of the urine, it can indicate infection or tubulointerstitial damage. When you see epithelial cell casts, it could be indicative of ATN. When you have red cell casts, it could be indicative of glomerulonephritis in the presence of vasculitis. So something about urine chemistry. There are 3 indices. One is urinary sodium. The other is fractional excretion of sodium, fractional excretion of urea. So urinary sodium, normal is around 10 to 20. If it is less than 20 or rather less than 10, then it can go towards HRS. If it's more than 40, it indicates towards intrinsic AKI. Fractional excretion of sodium, if less than 1%, is indicative of pre-renal AKI. If more than 1%, 1 to 2%, it is indicative of intrinsic AKI. Fractional excretion of urea, if less than 35%, is indicative of pre-renal, and if more than 50%, is indicative of intrinsic AKI. So what is this urinary sodium? It's an indicator of pre-renal etiology for renal dysfunction, given the avid sodium reabsorption by the renal tubules in volume depleted states. So like we have seen that the value of more than 40 millimole per liter is indicative of established non-rapidly reversible tubular injury. And if it's less than 20, it is suggestive of a hemodynamically reversible cause of renal dysfunction. So what is this fractional excretion of sodium? It is basically the percentage of filtered sodium that is excreted in the urine. And it is calculated in percentage. For this, we need the values of urinary and serum sodium and creatinine. And if the percentage is less than 1, then it could include, it indicates volume depletion. Whereas if it is more than 1%, it indicates established AKI. But the drawbacks are that the use of loop diuretics is associated with a FeNA in excess of 1%, regardless of the volume state. And where it has also been observed that FeNA less than 1% is associated with parenchymal renal disease. A bit about fractional excretion of urea. Less than 35% is indicated of a pre-renal cause. It may be superior to sodium in determining a pre-renal cause, but it is subjected to many confounding factors. So what do we expect from these novel AKI biomarkers? That it should be non-invasive, results should be rapidly available. There should be specific cutoff values to distinguish between normal and abnormal renal function. It should have the ability to differentiate between AKI, CKD, and pre-renal fluid responsive azotemia. We should be able to prognosticate outcomes in terms of need for RRT and mortality, and as a tool to guide the clinical management and allow monitoring. So what do these biomarkers describe? They describe the nature, site, and severity of renal injury. So a few biomarkers that I've mentioned is the creatinine and cystatin C. They would indicate injury, or they would indicate injury or the effects on the glomerular function. The retinol binding protein would show an effect on the tubular function, whereas interleukin 18 and KIM1, that's a kidney injury molecule 1, would be indicative of a tubular injury. We have various markers. There is a long list of markers, that is markers of the glomerular function, which is indicated by cystatin C, NGAL, retinol binding protein, hepcidin. Markers of the tubular, they also would show about the tubular function, except the hepcidin. The markers of the renal inflammation is calprotectin, hepatocyte growth factor, and interleukin 18. And markers of the tubular damage, we have a long list, but very few studies have shown that your NGAL, interleukin 18, cystatin C, these all markers is what we'll see in detail. KIM1 is also one more that I've included in my talk. So NGAL is neutrophil gelatinase associated lipocalin, or it is also known as oncogene 24p3. Now, it's a glycoprotein which is produced by epithelial tissues throughout the body, and it is plasma. The plasma NGAL is excreted via glomerular filtration. It is produced also in the distal tubular segments and released into the urine following tubular damage. It undergoes complete reabsorption in healthy tubular cells. After renal injury, within 2 to 4 hours, it can be detected. Now, the confounding factors are malignancy, sepsis, CKD, COPD, and pancreatitis. And subclinical AKI, wherein the renal injury has occurred, but the glomerular function is still preserved, is what we call as subclinical AKI. So there are a few studies that identified a few patients with a transient elevation in urinary and plasma NGAL levels without detectable changes in the level of serum creatinine. So the affected patients had a greater risk of complications, a longer stay in ICU, and a higher risk of mortality compared to patients without elevated NGAL levels. So golden window for effective therapeutic interventions will need to be investigated in future studies. There were also different studies in the ER department that was conducted. Suspected sepsis patients showed that a plasma NGAL level of more than 150 ng per ml had a sensitivity of more than 80% for predicting AKI, but the specificity was as poor as 51%. There was another study of around 635 patients, which concluded that a single measurement of urinary NGAL helped to distinguish AKI from the normal function, pre-renal azotemia, and CKD. And this is highly predictive of the clinical outcomes, including the need for RRT and admission to ICU. There was also a multi-center study in which 665 patients were included, which showed that adding serial plasma NGAL levels results to clinical judgment, it improved the prediction of AKI. In few acute, around 207 patients of acute heart failure, it showed that after control for pre-existing chronic cardiac or kidney disease, the serum creatinine, but not the plasma NGAL, it was an independent predictor of acute kidney injury. Now, another marker is interleukin 18, which is a pro-inflammatory cytokine and is detected within 6 to 24 hours after injury. Now, it is released into the urine from proximal tubular cells only after injury. Its confounding factors were inflammation, sepsis, or heart failure. Another biomarker was kidney injury molecular 1, which it's a transmembrane glycoprotein produced by the proximal tubular cells after nephrotoxic injury or ischemia. It is released into the urine from proximal tubular cells after this injury, detected within 12 to 24 hours after injury. The confounding factors are renal cell carcinoma, chronic kidney disease, chronic proteinuria, and sickle cell nephropathy. Now, there were few studies in post-CABG patients. The majority of the studies concluded that NGAL, interleukin 18, cystatin C, KIM1, and liver type fatty acid binding protein indicated AKI earlier than the serum creatinine also. There was this high risk CABG patients where serial levels of urinary tissue inhibitor of metalloproteinases and insulin-like growth factor binding protein 7 performed well in predicting early AKI and also renal recovery. But despite promising results in the research, it's still unclear how to use these new AKI biomarkers effectively after cardiac surgery. There was few studies in critical illness, critically ill patients where cystatin C, urine interleukin 18, urine NGAL, and plasma NGAL have shown mixed results, mainly as a result of heterogeneous patient population and difference in the timing and frequency of measurements. Now, some AKI biomarkers have the capacity either alone or in combination with the traditional renal function test and clinical judgment to predict the need for RRT. But there is insufficient evidence that biomarkers can indicate the optimal time for initiating RRT. Now, there's no data showing that the biomarkers are able to indicate when this renal recovery will occur, sufficient renal recovery occur, or when can this RRT be discontinued. So biological markers of recovery for the kidney, this study showed that decreasing levels of urinary NGAL and urinary hepatocyte growth factors in patients receiving renal replacement therapy were associated with greater odds of renal recovery, but the results of further studies are awaited. There was a study in 528 ICU patients where they showed that the levels of urinary NGAL, interleukin 18, and KIM1 were associated with mortality at around 1 year. So there was this study in 99 kidney donor patients where 176 were the recipients. They found that the donor urinary NGAL levels and not the plasma NGAL levels, they predicted the histological changes in subsequent donor kidney biopsies. And there was this higher risk of delayed graft function beyond 14 days, and that was worse in the 1 year graft survival. There were 41 diseased kidney donors in another study where they had taken up, which concluded that the plasma NGAL level was better in predicting the delayed graft function. Now, liver transplant patients, the urinary NGAL detected AKI at around 4 hours after the injury, whereas the plasma NGAL level at around 8 hours after the transplantation, whereas the GST, that's the glutathione S transferase, and KIM1 failed to detect the acute kidney injury. Now, serum creatinine, cystatin C, serum levels of interleukin 6 and 8, urinary levels of interleukin 18, NGAL, interleukin 6 and 8, they were all measured before and within 24 hours after liver transplantation. So in patients who developed AKI, all markers apart from cystatin C and serum IL-6 were elevated within the first 24 hours following the surgery.
Reshma, just a break and from because you have been I was just wondering because we are doing a lot of transplantation.
Yes, sir.
So what is the clinical application? Tushar and me both are here. So we both were thinking of that. What is the clinical application of this biomarker based earlier diagnosis of graft dysfunction as well as AKI in liver transplantation. So both allograft dysfunction in kidney transplantation as well as AKI in liver dysfunction. But how we can practically use it? Did you come across anything on that? Whether it can be implemented in our day-to-day practice?
No, practical application, no, sir. I just came through these studies that showed about this interleukin levels and NGAL levels.
Can our nephrology senior friends can comment? Rushi sir, if Das sir is here, Alok, you are the most. Rishit B is also there. आप दोनों एकदम ताजा ताजा पढ़े हो. Okay, I think we'll come back if Das sir has.
Yeah, Arindam.
Yes, sir.
So the problem is basically delayed graft function is in our cases. Basically, the definition says that if you have started the patient on dialysis within 5 days of period of time, or if the creatinine is not going to within coming down to its normal values within 5 days of time. Okay, so
Okay, sir.
those are the situations where we call it as delayed graft function. So there are several possibilities in those group of patients. One is whether we are dealing with acute rejection, which is antibody mediated rejection, or we are dealing with some ATN, ischemia, reperfusion injury, or ATN. So these three things can cause actually delayed graft function. Now, when we are talking about these multiple biomarkers, so they don't give much information if they are given means only standalone, like only one biomarker is in question. Let us say cystatin C. So we know that in cystatin C, if the GFR goes down, then the cystatin C will be elevated. But whether it will give us any clue regarding what is the etiology behind it, no, it will not. It just gives you an idea that how the GFR has been declined. Whereas all other biomarkers except IL-6, probably in liver patients, IL-6 will be of use since IL-6 and IL-8. So those are the biomarkers of tubular injury. And also it can be indicative of inflammation. So unless until you do a panel of biomarkers and see which one is elevated, where the injury is, some biomarkers are representative of GFR decline. Some biomarkers are representative of tubular injury, and that too in different segment of tubular injury. So if you are giving only alone, that's why probably it is bench to bedside is not happening. The laboratory, all the laboratory works we are doing, but we are unable to justify in clinical scenarios whether those will be useful. So whatever I studied in the urinary biomarkers, this is the crux basically, that alone it should not be used. It has to be a panel of biomarkers which will give us, and you have to establish a cutoff value. That is the rightly Rasmi has pointed out. Without cutoff value, you don't know where it is going. And there is no, all the animal models and other things are different, and we are, as a human being, we are different. that cannot be translated into human subjects, whatever the experiments are going on. Rushi, any thoughts?
No, Sudhir, I think you have covered excellently the whole topic for biomarkers. See, biomarkers to me today, they are still work in progress. The way I look at a biomarker is, why do I need a biomarker? I don't need a biomarker to tell me what I know clinically already. I need a biomarker for early diagnosis. Can they diagnose an AKI before I can diagnose it by, say, the rifle or Aiken criteria? Can the biomarker tell me, suppose I have a patient going for a cardiac surgery tomorrow, can a biomarker tell me the risk quantification of an AKI post-event? Can a biomarker help me diagnose the AKI even before the drop in output for 6 hours? So that's one indication. The second indication is a biomarker which can tell me about renal recovery. I have a patient with an ATN who is dialysis dependent, and I am waiting patiently for that kidney to recover. Is there a biomarker that can tell me that, yes, this is heralding recovery? Those kind of biomarkers would be relevant in clinical practice. At the moment, what biomarkers we have are basically telling us early signs of injury, whether it is glomerulus, proximal tubule, convoluted tubule, distal tubule, and so on and so forth. Markers for recovery are not yet there to predict the response as to what time frame the patient will take to recover from an AKI, which is the most important clinical thing. The other important thing from a biomarker that we would want is, can it predict the risk of going all the way to dialysis? In short, can it tell me the severity of the injury? So suppose when you do an NGAL as a marker of tubular injury, is it different in, say, injury versus ATN versus cortical necrosis? As of now, we don't have that data. We don't have a value of NGAL which tells us that, oh, at this level, the tubular injury will take longer to recover, or it can recover sooner. So those are still, I think, works in progress kind of data, which will evolve over time and help us to use these biomarkers better. But otherwise, I think you have already told, and I think for her first topic, she is really doing a great job. Congratulations for that.
Thank you, sir. I think I would ask Reshma to continue. Most of the questions on the biomarkers we have, but I think very important 2 points all of the students who are following. One is that not single biomarker, but maybe a panel, but practically the making a feasible panel of biomarkers. So be it in AKI or be it in sepsis and others, we have tried, but yet to come up with a practical solution of it. So we need to wait. And second is that not only prediction, but maybe a biomarker which can also give a time-based prognostication, timeline and prognostication would have been more practically useful. So which has also not happened. So keeping these two in mind, okay, Reshma, please carry on.
This was all about the laboratory investigations that we spoke until now. Just a slide on about this radiographical investigation. That's this renal ultrasound, where we use the B mode. In this, it's a quick non-invasive, you can say, assessment tool in which we mainly see the size of the kidneys and the echogenicity. So size mainly is if it's a chronic kidney disease, where we can comment about the size, whether it's an enlarged kidney where there can be could be infiltrative mass, or there's an acute rejection, or there's a renal vein thrombosis. In echogenicity, normally it is on the brighter side. The echogenicity is similar to that of the kidney, is similar to that of the liver and spleen. So we can have false positive and false negative findings also. So false positive findings we can see in case of vesiculoureteric reflux, full bladder, urinary tract infection, diabetes insipidus, pregnant patients, or an acute relief of obstruction. In these cases, we can find a false positive finding wherein the chelicus look dilated. False negative finding would be in cases of early obstruction or hypovolemia or retroperitoneal malignancy or fibrosis. So this is in terms of renal ultrasound. The second would be renal Doppler based resistive index, which is calculated, which is the normal value is around 0 to 1. And it basically tells us about the renal allograft status. I've not covered too much in detail about these radiographical investigations. I've just mentioned about the modes of these things, that is the CT and MRI.
Reshma, we would have a separate class on imaging for your nephrological diseases. We will have a very detailed sort of a,
Yes,
because
sir.
it's very important now, including the nuclear studies also. So we
Yes.
have imaging nuclear studies for it.
So that's all I have, sir, for this. So anything to be included?
I think in the next class, what you can add off, because the next class is mostly on etiologies and A. So I think some sort of work process flow to come up with a diagnostic approach, or maybe today diagnostic stewardship is also a very important aspect in any sort of way, because we have now the barrage of investigations available, but which one to be used in which situation and how to streamline and with the flow one by one, rather than doing everything together, is the more I think pragmatic approach. So a diagnostic stewardship and approach with a flow, you should work on it and present it in the subsequent class. Maybe
So like a flow
I will
chart,
give you,
step-wise
yeah.
process.
I would give you a not next week. You can do it after your, because you guys are presenting alternatively. So
Yes, sir.
you do it on a next. Don't take much of load. I think you should anyway. I would request if Das sir and Rushi sir is there, if you can really give a little bit idea on the urine analysis, which is very, very important, but mostly as just an urine examination, we seldom have a look into it. But I know the most of the astute nephrologists like you can make a pinpoint diagnosis by just an urine report itself.
Hi, Sudhir, should I go first?
Yes.
Yeah,
Sir, you grab the mic first, so you can please.
No, with his permission, Baba.
Right, sir.
Okay. So basically, when you look at urine now, it can actually tell you everything you want to know about the cause of the AKI. I mean, see, it is like this, that the color of urine, say, we start from there and you go to the most difficult test you do in the urine to tell more. If you look at a handbook of urine analysis, there'll be 30-40 pages there trying to tell you everything from the color to the smell to the specific gravity, density, osmolality, urinary scars, different type of cells you see in the urine routine, what they designate, crystals, etc., etc. I think they just confuse the whole thing. It is not that complicated. A concentrated urine is telling you that there is dehydration. A dilute urine is telling you that the patient has polyuria. That's all it tells you. The second thing is, the best test to look for in the urine is first the proteinuria and the presence or absence of RBCs, what we call as an active urinary sediment. So an active urinary sediment tells you that the kidney disease is likely to be glomerular in nature. So like Reshma divided, pre-renal, renal and post-renal. In a pre-renal, the urine should essentially be normal except for being concentrated. Okay, in a post-renal, the kidneys are fine. There is a problem draining that urine. So again, the urine analysis should not show anything major significant. So the urine analysis will show you an important finding only in the renal causes. So in the renal causes, basically we divide into 4 types: vascular, glomerular, tubular, interstitial. So these are the 4 compartments where it comes from. So depending on which compartment is affected, you will get appropriate findings in the urine. So it says it's a glomerular disease. So what findings you'll expect in the urine? Things like, presence of RBCs, presence of RBC casts, presence of proteinuria in the glomerular range. What does that mean? More than a gram a day, or a UPCR more than 1.0. That would suggest to you that yes, this patient has a glomerular pathology. Vascular pathology not involving the glomerulus directly depends on the type of vascular pathology. If it's like a renal artery disease, like a stenosis, again, the urine should be totally good, normal. However, it's an endothelial pathology like a thrombotic microangiopathy, then it will involve the capillaries of the glomerulus and give you a glomerular disease presentation. When it comes to tubular interstitium, the RBCs and RBC casts come because they are leaking through the glomerular permeability. In the tubules, there are no RBCs. So you won't see RBC casts in the urine in a tubular disease. What you will see is tubular casts, which are like the waxy casts, granular casts. So granular casts or muddy casts are the commonest kind of casts you will see in a tubular injury. So, when I was a fellow in Toronto, they made us spin the urine. Every time you had a consult, you had to spin the urine. And if you spin the urine on the centrifuge and you get a slide, you have to look at the waxy cast or the brown casts. If you're seeing the brown muddy cast, it's a ATN. That is a diagnosis. The other thing that is important in a urine analysis is the crystals. I myself don't know how much they signify in absence of patients with stone disease. I personally feel they're just a marker of tubular injury, nothing more. Or there's something that is in excess in the body which is trying to get into the urine because it has crossed the tubular maximum of that particular thing. I think more important is the urinary electrolytes and how to assess them. So look at urine spot sodium. Now that is a test you must have seen I order very frequently. What does it tell me? So in a kidney which is structurally healthy and functionally responding appropriately, a urine sodium tells me the volume status of the patient. If the patient has volume depletion, the job of the kidney is to retain salt and water, in which case the urine spot sodium will be on the lower side. So when I say low, I mean less than 10. There are no units to urine sodium, okay? So in the urine, sodium less than 10 means that the patient has intravascular volume depletion. If the urine sodium in a patient who you feel clinically is intravascular volume depleted, if it is more than 10, what does that tell you? It tells you that there is a structural injury to the renal tubule and it is not able to retain the salt and water that it should. So simple test like urine spot sodium gives you an assessment of whether the injury to the kidney is structural in nature or functional in nature. So a structural injury shows you a higher urine sodium and a lower will show you a lower urine sodium. Now the other test you see I order very frequently is a urine protein create ratio. Now why do I do that? Because that tells me what is the degree of proteinuria. So proteinuria of less than a gram is tubular, proteinuria of more than a gram is glomerular. Absence of proteinuria tells me that it is a purely functional injury to the kidney. It is not a structural injury. So three things: absence of proteinuria, functional injury, proteinuria less than a gram, tubular, more than a gram, glomerular. That's how you look at it. Now, other advanced tests like fractional excretion of sodium, fractional excretion of urea, fractional excretion of uric acid, they are all beautiful tests to look for volume status in more detail. But practically speaking, the first two tests I told you are all that we need in clinical practice. Only in patients where there is debate or confusion, you would do something like a fractional excretion of uric acid to prove to somebody that yes, the patient's volume status is so and so. But other than that, we don't really do that on a routine. Okay. So these are the basic urine chemistry that I normally look at. Other than that, advanced tests for urine are, whether is all aiming at the biomarkers which we discussed some time back, which are still kind of work in progress according to me. And I think that's all from my side for now.
Sir, Rushi sir?
Yeah.
You said no units to urinary sodium. I didn't get that.
No, it's a osmolality. It's a division factor, no? So when you do a fractional excretion of sodium, it's the urine sodium upon serum sodium. So the units will cancel themselves out. When you do a spot sodium, you'll have a unit, milliequivalents per deciliter.
Okay.
When you do a fractional excretion of sodium, you cannot have a unit because it's the ratio. serum to urinary sodium. So the units are going to cancel themselves out.
Rushi sir, I have one question. Ketan here.
Yeah, Ketan. Yeah,
When
Ketan.
we want to know a urinary spot sodium, this is a like practical point in the bedside.
Mhm.
If the patient has received some amount of Lasix or a
Yeah.
Ditor or a thiazide diuretic,
Hmm.
then should we do spot sodium, or how much hours of break should be there to really get a approximate value of the urinary spot sodium?
Yeah. So good question, Ketan. If the urine sodium is low, it is a valid answer. You can take it at face value. After giving a
Okay.
diuretic, if your urine sodium is low, that means it's a functional injury. If
Okay.
the urine sodium is high, now that is in the confusion range. Is it high because of a structural injury or is it high because of the diuretic?
Mhm.
So depending on the half-life of the diuretic that you have chosen to use, you will have to wait that much time before you can assess it with any certainty.
Okay. Okay. But still, we should check it. Means if you
Should
have
check it just because
diagnosed.
if it is low, then there is no more confusion.
Okay. Okay. Got it.
If it is high, then you can write in bracket on diuretic.
Okay. Thank you, sir. Very nice description
Is there any alternative to it, like your fractional excretion of urea or uric acid can be used? Can
No,
we
they are all
use
the
something
same.
when we are
They'll all be affected by diuretics equally.
so there is nothing,
There's no
sort of
foolproof way.
suitable alternative to it.
There's no foolproof way. And that is why these biomarkers started getting developed. Because if you say NGAL is a marker of tubular injury from ischemia, and that goes high and higher, and serially, like how we look at CRP or Procal, we get one report and the next report is higher, we know what's happening. Same thing with the biomarkers for now.
Okay. I think
So
that
I'll
that's
just
there
add-
any comment? Yeah.
I'll just add to what Rishi said, that there is another test for glomerular damage. What Rishi said was just to addition is basically, if let us say that you are not able to see RBC cast in the urine, but there are lots of RBCs in the urine, which is microscopic hematuria. Now, whether this microscopic hematuria is from the lower urinary tract or the upper urinary tract, that is from glomerular. So, and if you have a RBC cast, then you are sure that it is from the kidneys itself. And if it is not, then it is a difficult scenario where you can ask for the pathologist to have a look at the urine RBCs, and there will be dysmorphic RBCs in the urine. And if it is more than 20%, so then it indicates that the origin might be from the kidneys itself, not from the urinary tract. And for that, you require a special microscope that is called as phase contrast microscopy. So I think we must be having that microscope. If there is an uncertainty regarding the microscopic hematuria, you can send the sample, but that should be a fresh sample. Now the question to the trainees, that why there is a dysmorphic RBC you see in what is the pathology behind it? Anybody can answer? Alok?
Hello.
Or
Hello.
yes,
Hello.
Alok. Hello.
Hello.
Yeah, Alok,
Alok,
you're audible. Go ahead.
Yeah. So basically, as the RBC passes through the GBM, like glomerular basement membrane, and the filtration pathway, there will be structural deformity, and that will lead to the dysmorphic RBCs. And also we see for the acanthocyte, that is the
Birth cells.
some bird cells. Yeah.
But that is the difficult question. Whenever somebody asks you about this, then it is a controversial topic basically. Where is the origin basically, and what is the pathology behind it? So
Correct.
most of people might be wondering, and the explanation could be that when the RBCs are traversing the different barriers in your glomerulus, and that causes your RBCs to be crenated or kind of thing,
Dysmorphic.
or dysmorphic. But that many situations it is not actually. The counter argument for that is that the RBCs actually where when you traverse that can get destroyed as well. So many nephrologists have the opinion that it probably is the desiccation of RBCs due to the proximal converted tubule where it goes through and passes through. And during that period of time, due to salt and water absorption actively in that segment, so there is a desiccation of RBCs happening over there, and that causes the crenated RBCs or the dysmorphic RBCs. So you have to tell these 2 points, whichever is the nephrologist who is comfortable with, they can argue or disargue that. Okay, about that.
Yes.
So this is an important point which usually asked in the exam
So
practical.
phase contrast microscopy, Sudhir, in Mumbai at least is available with only one doctor, Sen Gupta.
नहीं, यहाँ पे भी है,
Mhm.
जसलोक में भी है वो.
Mhm.
Phase contrast is not difficult yet. वो just
No,
वहाँ
no,
पे
Sudhir.
change कर देते हैं
They don't have
modality.
phase contrast at Jaslok also now.
अच्छा,
So all phase contrast is going to only one doctor, Sen Gupta, is hematology origin,
हाँ हाँ.
who gives this report when we want it. And for urinary eosinophils, the only place which is accepting right now is Hinduja.
Hansel stain must be there. No,
Hansel
only
or
that.
White
Because
stain.
nobody
Yes,
else is willing to
Wrights
take a
or
sample.
Hansel stain. Correct.
Right.
Hmm.
So, Reshma, are you there?
Yes, sir.
So tell me, if let us say that we want to intervene during the, you know that the patient has gone into ATN and we are giving supportive services. Let us say that before dialysis, before the patient is non-oliguric kind of thing, but before dialysis, what type of intervention you want to give to the patient? Therapeutic interventions, so that frank ATN will not develop or the patient will recover from ATN.
So,
What are the studies?
so intervention wise, about the drugs, we would avoid it.
One is drug intervention, another is fluids. What type of fluid you want to use?
Status or avoiding hypoperfusion in
Yes.
terms of hypotension or any nephrotoxic drug, I mean, agent, same thing.
Yeah, those are the commonest one. Any other intervention kind of thing which has actually made some remark, but it was due to some complication, it was not clinically practiced.
Something like mannitol, phenylalodopam, anything like that? रश्मा आप पढ़ा है क्या? नहीं तो बोल दो, बाद में पढ़ के बताती हूँ.
नहीं, so ये part नहीं पढ़ा.
Sure.
Yes. ठीक है. So, what do know? Another one point to be noted, and yeah, is basically the fractional excretion of sodium in case of contrast nephropathy will be less than 1%. That is our MCQ question. So, although the patient goes into ATN, but the fractional excretion of sodium will be less than 1%. It is probably intensive vasoconstriction which is happening inside the kidneys, causing this. Although it is a pre-renal, initial period is pre-renal, later on it goes into ATN. So the MCQ, standard MCQ question will be like this. that which are the conditions where ATN, where you will get fractional expression to be less than 1%. Okay. Rushi, any
Sure.
other? Anything?
Nice, Sudhir. I think we have covered most of the diagnostic part right now.
But
So
it
next
is
time we are going
wonderful.
for
Means
this,
they have
right?
really studied.
Etiological diagnosis. I think Sudhir, like I said, these a lot of them are non-nephrology students also. So let
Yes.
them pick up the topics one by one at their speed instead of rushing.
Mm.
So let us go slowly so that we are covering the entire spectrum of kidney injury in the ICU.
Right.
So let them read
But-
around the topic and let us also discuss around the topic so it becomes easier for them and they don't feel, it's too big or too much. Slowly,
Correct.
slowly we'll take it ahead.
It should not be overwhelming. We'll
That's it.
slowly we'll
Too
pick
much
it up.
information also might not be great for this group. We should
Yeah.
go slowly and just let them pick up as time goes now, they'll pick up fast. In 2-3 months, we'll see they are all up to stream. Once
Sir,
they make a
also
habit of
I
reading around
just
the
add
books.
to Rushi's comment that both the time I have means this CME program I have means this teaching program I have attended. In those two occasions, everybody has done justice to the topic, and they have prepared it well. I
Oh,
completely agree with Rushi. They are excellently presented and very well done.
So next topic is etiology of
I
AKI,
just
correct?
also
Next
wanted
Thursday?
to comment.
Yes.
Yeah, Dr. Rishi and Dr. Das sir, this presentation was excellent. Dr. Reshma's presentation, no doubt. And the practical things Dr. Rishi definitely added that actually in real life, these markers are still not that very okay and easily available. So maybe we need some time. Yeah.
Right.
Thanks, Dheeraj.
Dheeraj.
It's nice to have a lot of faculty join, It's wonderful actually.
Also, good thing is that Ruchi sir is
Ah.
that our friends from Jaslok Hospital has also joined.
Yeah.
And slowly people actually not only you, I have also asked our critical care people to also connect them. And slowly, gradually, we will include other people from Mumbai's other
Whatever Zoom
institutions.
allows us, we can add
Yes.
slowly.
No,
But
sir, room is unlimited. You don't worry on that.
Okay,
So
fine.
slowly,
Because we should not
gradually,
have a
we will.
problem that our own students are not able to join. Because at least Jaslok and our students should always be able to join.
Sir, you don't worry about the room. We have an unlimited day on this.
Okay,
And
perfect.
and also, I think we should all together also request to people that if you also volunteer to present, so that would be, otherwise it would be at times very taxing on two fellows who are working, who have joined.
No, I am
So
sure
I would
once you
also
allow this,
request to.
our students from Jaslok will jump at it. So there should not be a problem if there are opportunities to be added. I'm sure the kids will be more than happy to take it.
Right, sir.
You can
Then
display the schedule
if you,
put it on the group, and I'm sure we'll have volunteers more than asking for the topics that
Yes, sir.
both of our students right now can't take. Okay.
right, sir. Right, sir.
Thank
Okay. So
Okay.
see you next week, same time, 7 on the
Thank you,
Thursday.
Arindam sir. Thank you
And-
for the excellent arrangements. Thank you.
Okay. Thank you.
Bye.